Thank you for the introduction. Good morning, everyone. I'd first like to thank the Congress for the honor of a podium presentation. I'm Rachel Ma, and I'm a recent graduate from UCLA undergrad and a clinical research assistant working with Dr. Yosef Nasseri at the surgery group of LA based at Cedars-Sinai Medical Center. We have no disclosures. Starting off with some background, converted minimally invasive operations are associated with worse outcomes. For both laparoscopic converted to open and robotic converted to open colectomies, patients experience higher blood loss, higher rates of complications, longer mean hospital stays, and higher costs. Prior studies have also reported that conversion rates of robotic surgeries are lower than those of laparoscopic surgeries. There are many prior studies that detail comparisons between the two minimally invasive platforms. However, no prior study has compared postoperative outcomes for converted laparoscopic and converted robotic surgeries. Therefore, our study aimed to compare the short-term postoperative outcomes of laparoscopic converted to open and robotic converted to open colectomies. As for our methods, we had a retrospective cohort study. We queried the colectomy data sets from the ACS NESQIP database between 2012 and 2020. Our inclusion criteria were elective surgeries and surgeries for neoplasms only. Therefore, we excluded urgent or emergent surgeries or surgeries for other etiologies. After identifying our patient population, we assessed demographics, comorbidities, short-term postoperative outcomes, and then ran univariate analysis as well as multivariable regression analysis with backward elimination to adjust for confounding factors. Here are our results. So our initial study population consisted of over 32,000 laparoscopic colectomies and just under 6,000 robotic colectomies. The laparoscopic colectomies converted at a rate more than 2 times as high as the robotic colectomies, yielding 3,200 laparoscopic converted to open cases and 276 robotic converted to open cases. And the difference between these two platforms' conversion rates was clinically significant at a p-value of less than 0.001. We then compared the two, the laparoscopic converted to open group and the robotic converted to open groups. In terms of patient demographics, there was no significant difference between the two groups. In terms of preoperative comorbidities, there were no significant differences except for higher rates of steroid use and transfusion in the laparoscopic group. And there were no significant differences in ASA classification, preoperative chemotherapy, or clinical T-staging of the cancer between the two groups as well. We then analyzed operative and postoperative outcomes, starting off with surgical complications. On univariate analysis, the robotic group had on average 48 minutes longer in operative time, as well as higher rates of organ space surgical site infection, septic shock, and unplanned reoperation. In terms of postoperative medical complications, in our univariate analysis, we found no significant differences between the two groups. Finally, we ran our multivariate regression analysis, and we adjusted for confounding factors, including demographics, comorbidities, as well as operative time. We found that in comparison to laparoscopic converted to open patients, robotic converted to open patients had no significantly increased odds of any postoperative complication. So in conclusion, commiserate with prior studies, our study too found that robotic colectomies have lower conversion rates. One may hypothesize that because that robotic converted to open surgeries would, or patients in robotic converted to open surgeries would fare worse than patients in laparoscopic converted to open surgeries, as only the very few most complicated cases convert in robotic surgeries. However, we found that there was no difference in outcomes following conversions from either platform. Thank you. I'm open for questions.